Okay, guys, can you see and hear me? Hello, yes. Can you see and hear me, by the way? Yeah. So I think the audio and video is clear. Okay. So we are meeting after quite a long time. I think it's been almost a month since we uh, came to the class, isn't it? So, nevertheless, not an issue. So, today we'll be continuing with where we left last time. And I think your need has been postponed. I feel it must be in March. I don't see anywhere before March, according to the discussions that I've been hearing from a few of my friends as well who's been in NB. So I don't think you'll be getting any sooner than that. So let us see. So fingers crossed. And even if it is a little faster, maybe in Jan and or February, also you should be prepared for that. So don't really think that the NEET exam is going to be in March only, and don't relax for that. So as I tell always, the only thing that is predictable is your preparation and your confidence of preparation. So that is the only thing that can be predicted. Apart from that, you cannot really predict what's really going to happen from NB's perspective. So nevertheless, so we do have a little bit of time so that we can cover the hepatology part today. Maybe if possible, even some gastroenterology we can cover if there is time. So last time I think we did discuss on the complications of cirrhosis just as a whole, but one of the important complications of cirrhosis, that is portal hypertension, is not yet discussed. So that's what I'm going to discuss today. So portal hypertension is what we are going to discuss. As far as portal hypertension is concerned, like you have different types of portal hypertension. In the sense, like portal hypertension itself has a tremendous number of complications, by the way. So first, you want to classify the portal hypertension into something called a prehepatic portal hypertension, probably an intrahepatic portal hypertension, or probably even a posthepatic portal hypertension. First, let us see what are the causes of prehepatic portal hypertension, that is before the entry into the like liver in the first place. So that is what we refer to as a prehepatic portal hypertension. And in that we have the number one cause, that is going to be the EHPO, that is extrahepatic portal vein obstruction. So usually it is due to portal vein thrombosis very commonly, but it can be due to some other conditions as well. But very commonly it will be due to portal vein obstruction. And second one, it could be due to splenic vein thrombosis, which is quite rare. And third, we have something called as a Bunty syndrome. So Bunty syndrome is an idiopathic syndrome. Usually the patient tend to have a congestive splenomegaly. Usually they tend to have a massive congestive splenomegaly. Along with that, they will be having varicose bleed, but there is no cirrhosis or extrahepatic portal vein obstruction. Plus, at the same time, patient will be exhibiting features of hypersplenism as well. So that is what we refer to as Bunty syndrome, which is typically idiopathic. Or you can remember Bunty syndrome as nothing but idiopathic congestive splenomegaly in the first place. Then we have intrahepatic portal hypertension. Intrahepatic portal hypertension you can split into three. One is called as this pre-sinusoidal intrahepatic portal hypertension. Then we have a sinusoidal intrahepatic portal hypertension. Then we have a post-sinusoidal intrahepatic portal hypertension. Pre-sinusoidal, everyone knows one of the very classic conditions that produces pre-sinusoidal portal hypertension. Can anyone tell what is the condition that produces pre-sinusoidal portal hypertension? Everyone should be aware of that, isn't it? What is the thing that produces pre-sinusoidal portal hypertension? No idea. I think this is a very important question as well, isn't it, for your exams? Maybe I can tell, probably give a clue. Yeah, parasite. Yeah. So I was about to give a clue, and Keshav answers schistosomiasis. Schistosomiasis is a characteristic example of something which can produce a pre-sinusoidal intrahepatic portal hypertension. At the same time, one other classical condition is there, which is not due to schistosomiasis, but we have something called an NCPF. This is really important for exam. So that is non-cirrhotic portal fibrosis. So that is called as NCPF, or simply referred as idiopathic non-cirrhotic portal fibrosis, or idiopathic non-cirrhotic portal hypertension. This is called NCPF. And then we have one more cause called congenital hepatic fibrosis, which is really not that important for you, but these two causes are very important for your exams. And second, we have sinusoidal portal hypertension. Sinusoidal portal hypertension is supposed to be the most common cause. of portal hypertension overall in the world, wherever you go, because this includes the most important condition that produces portal hypertension called as cirrhosis. And apart from that, there are quite a few drugs that can produce sinusoidal portal hypertension by causing, I mean, typically you can remember as cirrhosis also. One is amiodarone, which is really important. Second is methotrexate, which is also very, very important. And we have post-sinusoidal portal hypertension. As far as the post-sinusoidal portal hypertension, but intrahepatic is concerned, we have something called as SOS, that is called hepatic sinusoidal obstruction syndrome, or otherwise referred to as hepatic veno-occlusive disease. Usually happens in the setting of a post-hematopoietic stem cell transplant. So then we have something called angiosarcoma, and sometimes you can get even with a vitamin A toxicity. But I believe there are quite a few things that are important. So as I told you, the NCPF is very important in the pre-sinusoidal side. In the sinusoidal side, cirrhosis, amiodarone, methotrexate is very important. In the post-sinusoidal side, here, sinusoidal obstruction syndrome becomes really, really important. Other things, if you want, you can remember. Otherwise, you can leave. Not a problem. In post-hepatic, which means the cause of the portal hypertension is basically beyond the liver. It's above the liver. It's not below the liver or within the liver. So one condition is typically the IVC obstruction, or probably you can think about a hepatic vein obstruction, which is what we refer to as something called as a Budd-Chiari syndrome, which we'll be discussing later on. And after that, we have some cardiac conditions which can also cause portal hypertension over a period of time. So this is what we refer to as something called as a cardiac cirrhosis. But even though that kind of names should be really avoided in the first place. So as far as the cardiac disease is concerned, you can think about constrictive pericarditis, restrictive cardiomyopathy, a chronic right ventricular failure, which is a very rare cause. So these conditions can also result in development of portal hypertension. And apart from that, there are some other conditions which produce portal hypertension due to multiple different mechanisms. For example, there are conditions which produces pre-sinusoidal and sinusoidal portal hypertension. So examples of conditions that produces pre-sinusoidal and sinusoidal portal hypertension is vinyl chloride. So I don't know whether it has been asked or not. It's a very old PGA question. So vinyl chloride can cause portal hypertension due to multiple causes like pre-sinusoidal as well as sinusoidal portal hypertension. Then we have conditions that produces pre-sinusoidal and post-sinusoidal portal hypertension. For example, we have something called as mineral oil granuloma, which tends to produce this pre-sinusoidal and post-sinusoidal. It does not produce sinusoidal portal hypertension. It produces a combination of pre-sinusoidal versus post-sinusoidal portal hypertension. Then we have sarcoidosis, which causes similar finding. Sarcoidosis produces pre-sinusoidal and post-sinusoidal portal hypertension. It does not produce sinusoidal portal hypertension. By the way, so these are the conditions that produces portal hypertension by multiple different mechanisms, not just one isolated kind of a mechanism. So things you have to remember for sure: pre-sinusoidal schistosomiasis, you know that, then you can go for NCPF, which is very important. Then sinusoidal cirrhosis, methotrexate, amiodarone. Post-sinusoidal, you have your SOS, that is sinusoidal obstruction syndrome, otherwise referred to as veno-occlusive disease, which is typically going to happen in the setting of a post-hematopoietic stem cell transplant scenario. Then we do have complications of portal hypertension, which means portal hypertension is one of the complications of cirrhosis, and portal hypertension itself does have some complications. So what are the complications that you're going to encounter with portal hypertension? But before that, let us see some few points on cirrhosis and what cirrhosis is going to cause. And this is the overall pathophysiology of what we're going to deal with cirrhosis in the first place. First, if you think, let us put the liver here. Maybe let us draw the liver first. Liver. And we do have the heart here. So maybe I can... We can draw the heart here. So which is going to be the pulmonary artery, and it is going to be the aortic area. So maybe this is the interventricular septum, interatrial septum, just to make sure that this is the heart. And now we do have the great veins that are reaching the heart. I mean, this is only a conceptual diagram, so don't try to be very serious about it. But this does give you a lot of concepts. So let us assume this is the SVC, and let us assume this is going to be the IVC, inferior vena cava. And we all know that what is going to give rise to the inferior vena cava, it's going to be the hepatic veins that basically join with the inferior vena cava. Hepatic veins that basically going to join with the inferior vena cava to join to the right atrium, and then they enter the right ventricle and into the pulmonary artery. And of course, this is going to be the left atrium, left ventricle, and the aorta. And aorta is something that is going to give rise to this mesenteric vasculature. And at the same time, it is the one that's going to perfuse to a variety of other organs as well. For example, in this example, let us assume it's the kidneys that we're talking about. Kidneys we are talking about, and this is the mesenteric vasculature. The mesenteric vasculature, further it's going to split into the mesenteric capillaries. These mesenteric capillaries, of course, they are going to join to produce. Just hold on. Hello, sir. Sir, சொல்லுங்க sir. Okay, sir. Okay. Okay, sir. Okay. Okay, sir. Okay. ஒன்றுமே பண்ண வேண்டாம் சார். ஆக்சுவலாக வந்து ரெம்டெசிவிர் கூட கொடுக்கறது இல்லை, ஜஸ்ட் அப்சர்வ் மட்டும் பண்ணிட்டு. இல்லை சார், அப்சர்வ் மட்டும் மோஸ்ட்லி நந்த மேடம் பேஷண்ட் நிறைய பேர் வராங்க சார், அப்சர்வ் மட்டும் தான் பண்ணுறோம், வேறு எதுவுமே பண்ணுறது இல்லை. எதுவுமே இல்லை சார். காம்ப்ளிகேஷன் டெவலப் பண்ணால் தான் அதுக்கப்புறமா பார்த்துக்கலாம். மோஸ்ட் லைக்லி ப்ரெக்னென்ட் உமன் இது வரைக்கும் காம்ப்ளிகேஷன் டெவலப்பே ஆனதில்லை சார். ஒரே ஒரு லேடி தான் ஷி காட் சிவியர் கோவிட். அப்பார்ட் ஃப்ரம் தட் நம்ம ஹாஸ்பிட்டலில் மற்றவங்க யாருமே தி டோன்ட் டெவலப் காம்ப்ளிகேஷன்ஸ் மோஸ்ட்லி. அதனால் சேஃப் டு ஜஸ்ட் அப்சர்வ். ஒரு 2 வீக்ஸ் கிராஸ் பண்ணிட்டாங்கன்னா எந்த ப்ராப்ளமும் இல்லை. எதுவுமே வேணாங்க சார். சிஆர்பி பாசிட்டிவாக ஆனால் கூட கொஞ்சம் சிம்டமேட்டிக்காகவே இருந்தால் கூட நம்ம வெறும் சிம்டமேட்டிக் ட்ரக்ஸ் மட்டுமே கொடுத்து மேனேஜ் பண்ணிக்கலாம் சார். எதுவுமே என்ன சைடோ இல்லை எதுவுமே வேணாம் சார். ஸ்டீராய்டு வந்து அவங்க சப்போஸ் டெலிவரி பிளான் பண்ணால் யூஸ்ஃபுல்லாக இருக்கும். ஐ மீன் யூஸ்வலாக டெலிவரி எப்போ பிளான் பண்ணுவோம், அகைன் சிவியர் கோவிடாக இருந்தால் தான் பிளான் பண்ண போகிறாங்க. ஸோ அந்த டைமில் ஸ்டீராய்டு கொடுத்தா ரெண்டுத்துக்குமே யூஸ்ஃபுல்லாக இருக்கும். லங் மெச்சூரிட்டிக்கும் யூஸ்ஃபுல்லாக இருக்கும், கோவிடுக்கும் யூஸ்ஃபுல்லாக இருக்கும். இப்போ வேண்டாம்னு நினைக்கிறேன் சார். சரிங்க சார். ஓகேங்க சார். தேங்க்யூ சார். Sorry, I think we have been discussing on the capillaries. So these capillaries are going to unite together to form a different set of circulation. So they form the portal circulation. So this is what we call the portal circulation, by the way. I think I can join these things together. So I'm not going to, our screen isn't visible. Okay. Just hold on. I think now it's visible, right? Can you see it now? Yeah. Okay. Cool. Okay. Not an issue. So that's what we have been discussing. So they're going to join to produce this portal circulation. This portal circulation is going to enter the liver. And I mean, I'm not going to do the details of what all makes the portal circulation, by the way. So there are quite a few things that combine together anatomically to produce this portal circulation. But let us assume this is nothing but the portal vein. So, but we know that the inferior mesenteric vein and the splenic vein, superior mesenteric vein and the splenic vein combines together to form the portal vein, and the inferior mesenteric vein is going to join the splenic vein. So this is a very basic anatomy. So we're not going to go about that. So all the circulation combined together to produce the portal vein, and this portal vein is going to split into major portal veins and then into minor portal vein branches. Then once again, they're going to form the ultimate smallest segment, that is going to be the sinusoids. They're going to pour their blood into the sinusoids. Once they pour the blood into the sinusoids, they combine together to produce a hepatic vein. So this is how the anatomy is. So let us assume this is the sinusoidal level, and this is going to be the hepatic vein side, and this is the portal vein side. So we know in the sinusoids, you have the hepatic artery circulation also, that is also going to flow into the sinusoids, which you have discussed in the previous lectures itself. But nevertheless, here we are going to be concerned only about the portal circulation. We are not going to be concerned with the hepatic artery circulation. Normally, liver receives more blood from portal circulation or hepatic artery circulation. So what is your take? Normally, liver will receive most of its blood from the portal circulation or the hepatic circulation. Yes, correct. So normally liver receives almost 80% of the blood from the portal circulation, and only 20% of the blood is basically coming from the hepatic circulation. So which is really important. That's why I'm not drawing the hepatic artery here. And at the same time, this portal veins is also going to communicate with the systemic veins. We know that through certain areas. We have multiple areas that can actually have this kind of association, where they have this portal venous communication with the systemic venous communication. So let us assume these are the areas of physiological portosystemic shunting areas. But remember, this is not a very important site of portosystemic shunt in reality, but these areas are going to give problems in the future. So these are the areas where we have physiological portosystemic shunts. So anatomically, these are the areas that are going to contribute to the portosystemic shunts in a normal patient itself. Normally, they will not be very pronounced, but in the setting of portal hypertension and cirrhosis, they are going to be very pronounced, going to produce varices in those areas. So that's why I call it that. So what is the main problem in patients with cirrhosis? In the cirrhosis, the patient is going to have a sinusoidal hypertension. I already told you why the patient should have sinusoidal hypertension. So this is the place where they're going to have resistance, increased resistance, or probably I can call it as obstruction. So why the patient has sinusoidal hypertension? That is because of the cirrhosis. So let us assume the patient is having a cirrhosis. And because of that, the patient is typically going to have a sinusoidal hypertension. Sinusoidal hypertension. One of the main reasons why the patient has the sinusoidal hypertension is due to stellate cell retraction. Number one, I think we have studied that stellate cell retraction problem in the previous lecture itself. So one is stellate cell retraction, and second one is our reduced production of nitric oxide from the endothelium, which automatically happens in the setting of a cirrhosis due to stellate cell retraction. So these are the two reasons why you develop sinusoidal hypertension and cirrhosis. Once you develop the sinusoidal hypertension, there will be back pressure within the portal system. In the portal venous system, you're going to have significant increase in the back pressure. So this is going to increase the portal pressure dramatically. And that increase in the portal pressure is going to get translated into the mesenteric circulation. And this mesenteric circulation is going to go for increased capillary hydrostatic pressure. And because capillary hydrostatic pressure is a very important Starling force, that is going to result in probably ascites. So this is one of the important contributors of ascites, that is increased portal pressure, number one. And at the same time, this increased portal pressure will be transmitted through these areas of portosystemic shunting that is physiologically seen. And these areas are going to become varices. So, and these veins are going to get enlarged. And because of the enlargement of these veins, you are going to develop this varices as well. Number two. So number one is you have developed ascites. Number two, you have developed varices. And number three is you will develop some other complications as well. But other important reason why you develop this ascites is because of the sodium overload that you get because of the RAS activation. So why you develop RAS activation in the first place? There are multiple reasons why you can develop RAS activation. One is because to adapt this excessive blood that is actually there in the portal vein. So now the portal vein is basically having increased accumulation of blood. So to adapt this excessive blood in the mesenteric circulation, so they go for increased nitric oxide production in the mesenteric circulation. So this increased nitric oxide production will result in reduced resistance that happens as an adaptive mechanism. So once you develop reduced resistance in the mesenteric circulation, so now you have the aortic blood that now preferentially moves towards the areas of low resistance. So which means because there is low resistance here, more of aortic blood is trying to come into the mesenteric circulation. But the problem is a lot of blood is coming into the mesenteric circulation, but it cannot move out of the sinusoids because of sinusoidal hypertension. So that will actually lead to worsening of the complications and more increase in portal pressure and more increase in capillary hydrostatic pressure, more ascites and more varices and so on. It will keep on continuing. So this is generated as an adaptive mechanism, but at the same time, that is actually creating problems over a period of time. So it can work for a short run. It will try to prevent the patient's rise in portal pressure for some time, but it will not be durable for a long run. Over time, it's going to create more problems than benefits. So now you can see that because of the severe resistance at the sinusoid level, the amount of blood reaching the systemic circulation is actually quite less. So the amount of blood that will be reaching the heart will be actually quite less. So the amount of blood that is moving from the right ventricle into the pulmonary artery, right ventricle into the pulmonary circulation, and then back into the left atrium, and then into the aorta will be a little bit even more lesser. So because it is much less overall, like your cardiac output will try to reduce, but in general in cirrhosis, the overall cardiac output, if you take it, will not reduce. That is because of the strong increase in the sympathetic activity. Because of the strong increase in the sympathetic activity, your heart rate and the net cardiac output tends to even increase. So if at all in exams, if they ask you whether cardiac output in portal hypertension is reduced or increased or normal, you can write it can be normal or increased, but it's never reduced. So that is what we refer to as a hyperdynamic circulation. So to compensate for that, and because of the excessive sympathetic activity and adrenergic activity in the body, they'll go for hyperdynamic circulation, where they even sometimes have an increased cardiac output rather than a decreased cardiac output. And even though the patient is having a normal or increased cardiac output, majority of the blood is basically shunted towards the mesenteric circulation, but it's not coming out of the mesenteric circulation. So the blood, I can assume it's getting wasted, sort of wasted in the setting of a portal hypertension and cirrhosis. And if you take this kidneys, by the way, so the kidneys, to combat with that, they produce reduced amount of nitric oxide. At the same time, there is reduced perfusion that is happening to the kidneys. And coupled with that reduced nitric oxide in the renal vessels, there will be increased resistance in the kidneys, renal vasculature. And this increased resistance coupled with reduced perfusion to the kidneys, because most of the blood is entering the mesenteric circulation, will result in hyperactivation of renin-angiotensin-aldosterone system. And activation of RAS system is also mediated by the sympathetic system, because we know RAS can be activated by three things. So what are the three things that activate the renin? I've told you multiple times in the past. One is by reduced effective arterial blood volume. That typically happens in cirrhosis patients, of course, yes. And second is through the beta-1 adrenergic receptor through the sympathetic system. And of course, the third thing is through the prostacyclin, PGI2. So here, this reduced effective arterial blood volume is there. That is because most of the blood is entering the mesenteric circulation. And at the same time, most of the blood is actually locked in the form of ascites. So it's a third space loss. Peritoneal cavity is not supposed to harbor a lot of fluid. So in this situation, peritoneal cavity is taking a lot of fluid, and there can be pleural effusion. So most of the blood volume is actually locked up in the third space. So that is why you have low EABV in the first place. And along with that, you have excessive sympathetic activity, which can also stimulate the renin, which can further stimulate the angiotensin 2 and further stimulate the aldosterone, resulting in hyperactivation of RAS system. And this increased RAS system, over a period of time, it will result in increased sodium reabsorption. And this is the reason why the urinary sodium in patients with cirrhosis tends to be extremely low. It will be usually undetectable most of the times. And this increased sodium reabsorption is also one reason why you develop edema and volume overload state in patients with cirrhosis over a period of time. So one other reason, if you want to tell why the patient is having ascites, is because of the RAS activation. So because of RAS activation only, you're going to result in development of ascites in the first place. And as an adaptive response, one more thing that happens in the mesenteric vasculature is mesenteric vasculature usually contains alpha-1 receptors and beta-2 receptors. This is the distribution of receptors in any vessel. Alpha-1 is for vasoconstriction and beta-2 is for vasodilatation. We know that beta-1 is typically going to be there in the heart. But as an adaptation, what happens is the mesenteric vasculature will start developing more of beta-2 receptors than alpha 1 receptors. Again, because beta 2 receptors produces vasodilatation and reduce resistance, this increased portal pressure causes an adaptation in the mesenteric vasculature to produce more beta 2 receptors, to express more beta 2 receptors, to hold more blood because of the high portal pressure, and to reduce the portal pressure that acts as an adaptation, as I told you. So compared to that of the alpha 1 receptor. So these are the things that really happens in the mesenteric vasculature as well. And as I told you, if the hypoperfusion continues for a long time, so because the kidneys are going for hypoperfusion, and that is why you develop this hyperactivation of RAS system. And if the hypoperfusion continues for a long time and it becomes severe enough, they will develop in a prerenal failure, a special type of prerenal failure called as HRS, that is called as hepatorenal syndrome. So this is the problem number 3 that we are basically encountering. So one is the ascites that we encounter, second is the varices that we encounter, and third is going to be the hepatorenal syndrome that we're going to encounter in the setting of a portal hypertension and cirrhosis. But remember the fact that in patients with cirrhosis, hepatic encephalopathy happens due to different reasons. So it doesn't happen due to the portal hypertension. Portal hypertension is not the cause of hepatic encephalopathy. It's a sign of liver cell failure. As I told you, if you take the ultrastructure and see, you can see the sinusoids here. Once you see the sinusoids here, you know very well that from one side you are going to have hepatic artery blood, and another side you're going to have the portal venous blood, and on the other side you're going to have this sort of hepatic veins, by the way. So I can write hepatic veins here. So they're going to drain into the hepatic veins, and you do have this hepatocytes and the space of this here. This diagram I think we have discussed already. So this portal blood is going to contain high amounts of ammonia and many other ugly components also, which we'll discuss later on. So, and all these substances are basically filtered while they're passing through the sinusoids. When they're passing through the sinusoids into the hepatic vein, for example, this ammonia will be taken up by the hepatocytes, and they're going to form urea. And urea is the one that is going to be released into the hepatic vein back. So in the setting of sinusoidal hypertension, or in the setting of hepatic failure where the liver cells are destroyed, so there will be stellate cell retraction that will produce hypertension. That is fine. But whatever blood that is moving into the hepatic vein won't be filtered by the hepatocytes, and this blood will directly enter the systemic circulation, so which is going to contain a high amount of ammonia rather than urea. So this is the reason why you develop hepatic encephalopathy. So which means hepatic encephalopathy is basically a sign of liver failure, and it's not a sign of portal hypertension. So that's what you need to really think about. So it doesn't happen because of portal hypertension. It happens due to hepatic failure. Remember the synthetic function, that is low albumin and coagulopathy. So these are the two problems due to loss of synthetic function, and that is due to liver failure and not due to portal hypertension, by the way. And again, hepatic encephalopathy is not a sign of portal hypertension. Again, it's a feature of liver failure. So whatever treatments we are going to give for portal hypertension will not work for hepatic encephalopathy or coagulopathy. For coagulopathy and hepatic encephalopathy, we have to treat in a completely different way compared to how we manage a portal hypertension. So let us see how we are going to manage a portal hypertension in a nutshell. I mean, the problems due to portal hypertension in a nutshell. So suppose one of the main reasons for this problems is increased portal pressure. So that's the main problem. So this is the main event that happens in any patients with portal hypertension and cirrhosis. So how to tackle this portal pressure and how to lower the portal pressure. So let us assume you have number one problem in acute variceal bleed. In acute variceal bleed, what really happens? In patients who are having acute variceal bleed, the first thing you need to reduce is the portal pressure. How to reduce the portal pressure? So one of the main reasons for increased portal pressure is this low resistance pulling a lot of blood from the aortic circulation. So you need to increase the splanchnic resistance. Splanchnic resistance. So how will you increase the splanchnic resistance? So how to increase the splanchnic resistance is by giving a drug called terlipressin. And second thing, you can use another drug called octreotide also, that also increases the splanchnic resistance by causing vasoconstriction of the splanchnic circulation. Once you increase the splanchnic resistance, the blood does not really flow into the portal circulation. There can be acute drop in the portal pressure, resulting in resolution of the variceal bleed. So that is number one. And apart from that, you need to tackle with the ascites. As I told you, ascites is due to two reasons. One is going to be due to increased portal pressure, and second is due to the sodium overload. But of course, the sodium overload is going to be more important for development of ascites and volume overload state. So most of the times we going to tackle with diuretics. So that's how you're going to manage an ascites. You give a combination of loop diuretic with the mineralocorticoid receptor antagonist like spironolactone. And many students do ask me why you cannot give an AC inhibitor. So remember, if you remember in the nephrology lecture, I have told you whenever there is a hypoperfusion, it's better not to give AC inhibitor. So this is a condition which typically causes severe hypoperfusion. So that is the reason whenever you don't have sufficient perfusion to the kidneys, it's better to avoid ACE inhibitors. So that's why we don't give ACE inhibitors, because ACE inhibitors can worsen the hypoperfusion and they can make the kidneys suffer from more hypoperfusion, and they can go for severe renal failure and so on. So we don't really give ACE inhibitors here. So the one way where you can prevent the sodium reabsorption is to give an aldosterone blocker. Aldosterone blockers are very effective here. So number two, and it's been proven that high aldosterone in patients with cirrhosis may result in remodeling of the liver to put towards more fibrosis, and they can cause more and more cirrhosis and more effects on the liver. So that is why blocking the aldosterone receptor is really, really helpful in that scenario as well. Apart from that, if the patient is having a refractory ascites, you can use one more thing also. Like for example, there are other drugs that are shown to be a little beneficial in patients with severe ascites. Like for example, you can give a midodrine. You can ask how midodrine works. Midodrine is an alpha agonist. So which means if you stimulate the alpha receptors more by giving midodrine, you might really result in development of more splanchnic vasoconstriction and more resistance in the splanchnic circulation, resulting in reduced portal pressure and so on. So that is one more drug where you can use. And suppose for prophylaxis, so treatment of varicose bleed, I told you terlipressin or octreotide is what you're going to use as a first line drug. But prophylactic drug, often you would have seen many patients will be receiving beta blockers for prophylaxis. Once again, you can understand why we use beta blockers. That is because these beta 2 receptors are basically upregulated in the portal circulation. Suppose if you give a non-selective beta blocker, that only can block the beta 2. You cannot give a cardioselective beta blocker because that cannot block the beta 2 receptor. So if you give a non-selective beta blocker like propranolol, which has beta 2 blocking property, which can result in reduced vasodilation of the splanchnic circulation, resulting in increased resistance of splanchnic circulation, resulting in reduced portal pressures, and thereby for prophylaxis of varicose bleed, you can use propranolol, not a problem. And apart from that, for hepatorenal syndrome, once again, the first line therapy that we use is terlipressin, because the main reason is because more blood is entering here. That is why reduced perfusion to the kidneys is happening. So increase the resistance in the splanchnic circulation, and so that you can push more blood into the other organs like kidneys. So that is why again terlipressin is one of the primary modalities of therapy in patients with hepatorenal syndrome. Plus along with that, usually we give albumin, because hepatorenal syndrome is a typical pre-renal failure. It's due to hypoperfusion. To increase the perfusion, we can give albumin. Remember why we use albumin instead of normal saline, because here the patient is already volume overloaded, so it's not very ideal to use a normal saline in this kind of patient. So to increase the vascular volume, you can use albumin, especially the 5% albumin is what we use. That is the salt-free albumin is what we are going to use. Clear? Sorry, 20% albumin is what we are going to use, which contains much lesser salt compared to the routine 5% albumin that we are going to use for hypovolemic patients. So that is completely different. So we don't want to go into that. So acute varicose bleed, you use terlipressin, octreotide. For prophylaxis, you use beta blockers. For ascites, use diuretics. Probably in severe cases, you can use midodrine. Hepatorenal syndrome, anyway, you're going to use terlipressin and albumin, by the way. But if all these things becomes refractory, so acute varicose bleed becomes refractory, ascites becomes refractory, and your hepatorenal syndrome becomes refractory. So what do you do? For all, they ask you the best treatment. Of course, the major culprit for all these things in a patient with cirrhosis is the liver failure. So of course, I need to go for transplant. That is orthotopic liver transplantation. That's going to be the best for all these situations. But there is a bridge therapy that we can use. So till you go for the transplant, or in some patients to prolong the life, you can use one bridging therapy. That is what we refer to as TIPS. So that is called transjugular intrahepatic portosystemic shunt. So what do you mean by this transjugular intrahepatic portosystemic shunt? The main problem is increased portal pressure. That's causing all these three complications which I've told you. To reduce the portal pressure, what I'm going to do is I'm going to shunt the portal blood to the systemic circulation directly. So which means I'm going to put a probe. I'm going to come in through the SVC, and enter the IVC through the right heart and come into the hepatic vein. And once I come into the hepatic vein, I'm going to puncture the hepatic parenchyma, and through the hepatic parenchyma, and I'm going to make way and put a graft. We typically use a PTFE graft, polytetrafluoroethylene graft. So to make a connection between the hepatic vein and the one of the major branches of the portal vein. So what happens is the moment you make this communication, you are actually bypassing the sinusoids. Here the sinusoids are bypassed, and the portal venous blood that is already under serious pressure is going to directly move into the hepatic veins. So which means this TIPS is a very, very effective procedure that can significantly reduce the portal pressure to a great extent, thereby alleviating all these three complications. But again, if you believe TIPS won't be effective for problems of synthetic function or problems due to liver failure, so they aren't going to work. TIPS will reduce the portal pressure by shunting the blood from portal vein into the hepatic vein directly by bypassing the sinusoidal hypertension area, but it cannot deal with problems due to liver failure. So which means in hepatic encephalopathy, it won't work. In fact, it can worsen the hepatic encephalopathy. So whatever ammonia that's been accumulated in the portal circulation is actually shunted directly into the systemic circulation. So in fact, TIPS increases the risk of hepatic encephalopathy, and post-TIPS encephalopathy is quite common and it can be managed. But in fact, severe encephalopathy, any moderate to severe encephalopathy is actually a straight contraindication for doing a TIPS. You cannot do a TIPS. Only in patients who don't have moderate to severe encephalopathy and patients who only have mild encephalopathy, you can go for TIPS. Otherwise, any moderate to severe encephalopathy is actually a contraindication because TIPS is known to worsen encephalopathy. Number one, very, very important. And you have other problems due to TIPS as well, but you need to remember that problems due to liver failure will not be alleviated with TIPS. Only problems due to portal hypertension will be alleviated with TIPS. So for acute variceal bleed, if it's refractory, for ascites, if it's refractory, and for hepatorenal syndrome, if it's refractory, probably you can think of doing a TIPS maybe. And these are some of the important basic knowledge that you need to know before we go into other advanced topics on portal hypertension. If you understand this, we can move on to the next topic. Do you understand this one? So whatever I've told you till now. So what's really happening in patients with cirrhosis and portal hypertension, where the problem is. Yes, cool. So one more prophylactic drug that we can use in patients with cirrhosis to reduce the risk of variceal bleed, it's a prophylactic drug, is nitrates. Nitrates also can be used. I mean, this is less effective compared to propranolol, by the way. Suppose if you want to use nitrates, nitrates are basically going to be effective at this area. So as I told you, one of the important reasons for sinusoidal hypertension is reduced nitric oxide. So probably giving a nitrate through first pass metabolism, they can increase the production of nitric oxide. So that's how nitrates work, by reducing the portal pressure. So it's been proposed as a second line drug in patients with varices to reduce the incidence of variceal bleed. So after beta blockers, suppose if you have a beta blocker contraindication like severe reactive varices, you can use nitrates in those people. But apart from that, it's not that effective like beta blockers, and it can also cause little bit of splanchnic vasodilation. So the net effect anyway is good, but it's not that good as beta blockers. So that is what we need to know. So these are the problems that you're going to encounter due to portal hypertension in the first place. So let us go on and discuss what are the other things that you're going to encounter. Suppose if you want to know other complications that are going to happen due to portal hypertension. So you have some pulmonary complications of portal hypertension. So what are the pulmonary complications of portal hypertension? So number one is pleural effusion. Once again, it is due to volume overload state. And at the same time, they can go for something called hepatic hydrothorax. It's a severe form of pleural effusion. So remember, hepatic hydrothorax is typically due to the ascitic fluid entering the pleural space. Very commonly, it will be on the right side, more commonly. because sometimes through the openings in the diaphragm, the acidic fluid can directly enter the pleural space, resulting in a massive pleural effusion. That's what we refer to as hepatic hydrothorax, which is quite common on the right side compared to the, of the left side. And next, you can develop something called hepatopulmonary syndrome, which we'll be discussing later on. And third complication is something called as portopulmonary hypertension, PPH, which can also happen due to portal hypertension. And because of ascites, they can develop another complication called spontaneous bacterial peritonitis, which we'll be discussing after some time again. So all these are complications of portal hypertension: SBP, pleural effusion, hepatic hydrothorax, HPS, that is hepatopulmonary syndrome, and portopulmonary hypertension. All these seem to be complications of portal hypertension as well. And how will you diagnose portal hypertension? So now, what are the modalities of diagnosis of portal hypertension? Of course, the clinical features are very, very important. That presence of that caput medusa or presence of splenomegaly. Splenomegaly is quite common. So usually in clinical findings, you will have ascites, plus or minus you can have pleural effusions, and patients may have splenomegaly. And along with that, other signs of cirrhosis may or may not be there depending on the cause of the portal hypertension. So nevertheless, so these are the characteristic features of clinical features of portal hypertension. And ultrasound plays a very vital role in diagnosis of portal hypertension, especially the most important modality we use is the Doppler of the portal vein. So where we need to see the portal vein diameter. I think I have told you this already. If the portal vein diameter is more than 1.3 centimeter or 13 millimeter, very important question in exam, that can tell you that the patient is probably having a portal hypertension. This is a very important number that you need to know. So portal vein diameter more than 1.3 centimeter. And apart from that, we have something called mean portal flow velocity. So we have something called portal flow mean velocity. If there is a sinusoidal hypertension, the velocity will be less, so which means the blood will be stagnant. So the velocity will be less than 12 centimeters per second. So which is also a very important number. So you can remember, probably you can remember as 12 and 13 here, less than 12 centimeter per second and more than 1.3 centimeter. Or the flow can be completely inverted. So normally the portal flow should be towards the liver, but in this case it can be away from the liver. So which is a very severe case of portal hypertension, and the patient may have portosystemic collaterals, so which can also be seen in the ultrasound sometimes. So ultrasound plays a very important role, but this is going to be really, really important, that 1.3 centimeter cutoff. And sometimes ultrasound, you can see the etiology also. Even etiology can be seen. For example, if it's a cirrhosis, you can see the nodular liver. If it's you can also see the portal vein thrombosis or a splenic vein thrombosis in the ultrasound, especially in the Doppler. So all these things can help you in diagnosing the etiology of portal hypertension as well. And apart from that, we have something called HVPG, which is not often used. But if they ask you what is the gold standard for finding out the diagnosis and the type of portal hypertension, your answer is HVPG only. So everyone knows what you mean by HVPG. HVPG stands for hepatic venous pressure gradient. So which is typically the gold standard for diagnosis as well as the classification for portal hypertension in the first place. So you can really tell the exact location of portal hypertension, whether it is pre-sinusoidal or post-sinusoidal or pre-hepatic or post-hepatic or intrahepatic, intrasinusoidal, everything you can tell with HVPG. And at the same time, you can also categorize the severity of portal hypertension, because at a particular level of HVPG, you get certain complications of portal hypertension, like what point you will get varices, what point you generally tend to get epidural syndrome, at what point you tend to get spontaneous bacterial peritonitis. All these things can be told with the help of HVPG. So HVPG is both diagnostic as well as it can be prognostic as well. But it's not routinely done because it's a highly invasive procedure. Just for the sake of diagnostication and prognostication, you need not really do a HVPG. So what is the basic concept of HVPG? You're going to measure two pressures. So to know HVPG, you need two more pressures. One is called wedge hepatic venous pressure, and the second one is the free hepatic venous pressure. That's called FHVP, so called free hepatic venous pressure. One is the wedge hepatic venous pressure, and second one is going to be the free hepatic venous pressure. So we are going to find out the wedge hepatic venous pressure and how we are going to find out the free hepatic venous pressure. So let us take a case of a cirrhosis first. So normal case, then we'll go on to the cirrhosis case. So we know that you have an IVC basically. So let us assume you have the portal vein here, portal vein, so portal system, and portal system is going to communicate with the sinusoids. Let us assume these are the sinusoids that are present within the liver. And after some time, it's going to enter into the hepatic veins under the IVC. So this is the IVC and this is the portal vein. And let us assume this area is the sinusoidal area to make sure that you understand. So we know the portal vein blood enters the sinusoids and goes out through the hepatic veins to reach the IVC. So this is the normal anatomy and normal circulation physiology that we are seeing. So sinusoids. So what we are basically going to do is going to come through the IVC, or maybe come through the SVC and then enter the IVC. And while coming into the IVC, we are going to one of the branches and we are going to occlude that with a balloon. And whatever pressure you measure prior to this occluded area is what we refer to as something called as a free hepatic venous pressure before the balloon occlusion. And whatever pressure you're going to get after occlusion with the balloon is what we refer to as a wedge hepatic venous pressure. That's called WHVP. So free hepatic venous pressure is the total pressure. Basically, the total pressure that you get in the IVC system is the free hepatic venous pressure. And once you occlude this area with a balloon, and the pressure you are going to get is the wedge hepatic venous pressure. So what do you mean by basically the wedge hepatic venous pressure? Wedge hepatic venous pressure is basically going to demonstrate the pressure within the sinusoids. So whatever the pressure is going to be there in the sinusoids, that is what is going to be indirectly measured using the wedge hepatic venous pressure. It's the same mechanism as that of what you get in pulmonary capillary wedge pressure, where indirectly by occluding the one of the branches of the pulmonary artery, you do get the pulmonary capillary wedge pressure, which is nothing but an indirect approximation of a left atrial pressure. So similarly here, the wedge hepatic venous pressure is an indirect way of measuring the sinusoidal pressure. You can understand that. And of course, the free hepatic venous pressure is the net pressure in the system that includes the IVC pressure. Along with that, your sinusoidal pressure and everything will be together added to get the free hepatic venous pressure. So let us see what's really going to happen. So in different situations. So I can write what will happen in prehepatic portal hypertension and what will happen in pre-sinusoidal intrahepatic portal hypertension, what will happen in sinusoidal intrahepatic portal hypertension, what will happen in post-sinusoidal intrahepatic portal hypertension, and what will happen in post-hepatic portal hypertension. So we have multiple different causes which you have seen already. So first, let us see what will happen in the sinusoidal level. So one is called we know we are going to measure the FHVP, that is the free hepatic venous pressure. Then the second measurement is wedge hepatic venous pressure. And the difference between the two is going to give rise to the hepatic vein pressure gradient. So that is HVPG. So this is what you're going to get. So let us see what will happen in a sinusoidal hypertension, which is typically seen in cirrhosis. So free hepatic venous pressure in a sinusoidal hypertension will be normal. So why? Because the sinusoids are the ones that are showing the hypertension here. But the overall free hepatic venous pressure, that is the IVC pressure, is supposed to be normal. That is hepatic venous pressure, is supposed to be normal in the setting of a sinusoidal hypertension. Then the wedge hepatic venous pressure, of course, is going to be tremendously elevated in sinusoidal hypertension. That is because the resistance that is seen in the sinusoidal area. And when you minus, when you see the difference, that is the wedge hepatic venous pressure minus free hepatic venous pressure, the hepatic venous pressure gradient, that is HVPG, is going to be definitely increased. So this is very, very important. A common question asked in exam. HVPG is increased in which hypertension? That is sinusoidal hypertension. Especially the most important example is cirrhosis. If you take a pre-hepatic and pre-sinusoidal, the problem is before the sinusoids in this area. So in this situation, if pre-hepatic and pre-sinusoidal problems, typically your free hepatic venous pressure and wedge hepatic venous pressure will be normal because there is no problem in the sinusoids or in the IVC circulation. So the HVPG will be normal. Suppose if you take pre-sinusoidal, same problem because it's problem in before the sinusoid. So the wedge hepatic venous pressure as well as the free hepatic venous pressure will be normal. And so the HVPG also will be normal. In post-sinusoidal, so the free hepatic venous pressure will be normal because again, free hepatic venous pressure is a measure of hepatic vein pressure. So here in the post-sinusoidal area, the problem is not in the hepatic veins. The problem is in the post-sinusoidal region before the formation of hepatic veins. So the post-sinusoidal region, the free hepatic venous pressure will be normal, but the wedge hepatic venous pressure will be increased because once again, I mean, we don't really measure the sinusoidal pressure directly. We are indirectly measuring. So ultimately, it will also be increased. And definitely, you will see increase in the hepatic vein pressure gradient. And what about post-hepatic? Post-hepatic, the free hepatic venous pressure will be increased because it's due to congestion, because probably of some cardiac problem or hepatic vein obstruction. So the hepatic venous pressure will be increased. Because the hepatic venous pressure is increased, this IVC pressure will be backflowing into the sinusoid. So the sinusoidal pressure also will be increased. That is seen as elevated wedge hepatic pressure gradient. So overall, there will be a normal hepatic vein pressure gradient only. So both are increased. So when you see the difference, it will come back to normal. So remember, in most of the situations, hepatic vein pressure gradient is normal only. In one situation where you need to know for exams where HVPG is increased is cirrhosis, classical example. So this is where your exam questions will be. So most of the other situations, your hepatic vein pressure gradient will be normal. In patients with sinusoidal obstruction, in patients with sinusoidal resistance, in patients with cirrhosis, that is the place where you're going to have a elevated hepatic vein pressure gradient, because this is a typical example of a sinusoidal hypertension. That is what is going to be measured by the wedge hepatic venous pressure. So which is what is going to be very, very important. So based on the level of HVPG, you can even tell the complications that's going to happen. So if they ask you the normal HVPG, which is very important. So many theoretical questions are there in HVPG. So that's why I'm discussing this. A normal HVPG is typically in the range of 1 to 5 millimeters of mercury. So definition of portal hypertension, especially sinusoidal portal hypertension, will be there if HVPG is more than 6 millimeters of mercury. Suppose if the HVPG is more than 6 millimeters of mercury, this is where we typically call it as a portal hypertension. So, I mean, whenever HVPG is high means, you know very well it's a sinusoidal or maybe a post-sinusoidal portal hypertension. But in reality, whenever HVPG is raised, we are always going to talk about a sinusoidal portal hypertension, that is classical of a cirrhosis. But what is the portal pressure? I mean, we didn't talk about that. So what is the normal portal pressure? So we have talked about portal pressure. So what is the normal portal pressure? I mean, you're not talking about HVPG here. You're talking about real portal pressure. Real portal pressure is 5 to 10 millimeters of mercury, or we can write as 7 to 14 centimeters of water. This is a normal portal pressure. So when you call it as a portal hypertension. So here there is nothing like sinusoidal. Universally, whenever the portal pressure is more than 10 millimeters of mercury, that is more than or equal to 11, this is the point where we are going to call it as a portal hypertension. So as far as the HVPG is concerned, if the HVPG is more than 6, we call it as portal hypertension, or otherwise referred to as sinusoidal portal hypertension. So if the portal pressure is more than 10 millimeters of mercury, or if the HVPG is more than or equal to 6 millimeters of mercury, that makes the diagnosis of portal hypertension. Ultrasound wise, if the portal vein diameter is more than 1.3 centimeter, or the mean portal velocity, blood flow velocity, is less than 12 centimeters per second, these are the numbers that you need to know for exams to tell that the patient is probably having a portal hypertension in the first place. And how HVPG can be prognostic, which means HVPG can tell you the development of complications as well. So first of all, we have two things. One is called a compensated cirrhosis. Second one, we have something called a decompensated cirrhosis. Decompensated cirrhosis. So whenever portal vein, HVPG is less than or equal to 16 millimeters of mercury, usually the patients will be having a compensated cirrhosis. Whenever the patient is having more than pressure of more than 16 millimeters of mercury, usually they will go for decompensated cirrhosis, which means where the patient will have a compensated or decompensated cirrhosis also based on the hepatic vein pressure gradient only. Suppose the patient is having a HVPG of 10 millimeters of mercury. This is the place where you start developing varices. Patient will start developing varices even though they don't go for bleeding. This is the time where they start developing varices in the first place, number one. Second, whenever the HVPG is around 12 millimeters of mercury, this is the place where they start developing the variceal bleeding, even though it will not be refractory or severe. They will start developing this mild, minimal, or moderate variceal bleeding. So whenever the portal pressure becomes 16 millimeters of mercury, this is the time where the first decompensation will happen. So you will encounter first clinical decompensation due to cirrhosis, where the patient may get severe jaundice or signs of liver cell failure or more variceal bleeds. So this is the time that they will get. Once it becomes more than 16, there is always a risk of variceal rebleeding, which means they will start getting bleeding again and again. And once the portal pressure, HVPG reaches 20 millimeters of mercury, there is increased risk of uncontrolled varicose bleeding, which means there will be a failure to control this varicose bleeding. Increased risk of uncontrolled varicose bleeding. And at the same time, once it reaches 22 millimeters of mercury, it indicates very high risk of death due to cirrhosis. And once it reaches 30 millimeters of mercury, it indicates risk of developing spontaneous bacterial peritonitis. So once the HUPG reaches 30, there is a risk of spontaneous bacterial peritonitis. At 10, they develop varices, and usually at 20, they develop refractory varicose bleeding. So 3 numbers is important for exam, that 10, 20, and 30. 10 for development of varices, 20 for refractory varicose bleed, and 30 for development of spontaneous bacterial peritonitis. These are the 3 numbers that you need to know for exams. So these are the 3 things they usually ask. So beyond this, where you develop this problem. So how to reduce portal pressure? So is there ways to reduce portal pressure? Is there any treatment for reducing portal pressure? Yes, you do have. So one way to reduce the portal pressure is to reduce the splanchnic resistance, which means you're causing a splanchnic vasodilation. Already we have discussed in the basics, just I'm recapping that. So to reduce the splanchnic resistance, how you're going to reduce the splanchnic resistance? Number 1, by giving a non-selective beta blocker like propranolol, which I've told you already. And second, by giving terlipressin octreotide. Sorry, not reducing, it's increasing, I guess. Sorry, increasing splanchnic resistance. So once you increase splanchnic resistance, you're going to have a reduced portal pressure. I think we have discussed that already. So one is terlipressin octreotide. All these things are going to increase the splanchnic resistance, thereby reducing the portal pressure. And third is you have alpha-1 agonist. Alpha-1 agonist, very common example is midodrine. So these are the 3 ways, 3 drugs that basically tend to increase the splanchnic resistance, thereby reducing the portal pressure. And second is to reduce the sinusoidal pressure or reduce the sinusoidal resistance. So once you reduce the sinusoidal resistance, you can basically reduce the portal pressure because the blood movement across the sinusoids will be increased. So one such drug is nitrates, which I've told you already, very infrequently used. And second, even certain alpha blockers have been shown to be effective in this situation, not used, and angiotensin receptor blockers can be tried, but I mean, these are very, very infrequently used. We don't use because of the high risk of other complications that are associated with these drugs in the first place. So very commonly used drugs are these drugs only in appropriate scenarios. But the first 2 drugs are extremely commonly used in clinical circumstances. If you want to know interventional therapy, these are the drug-related therapy. So drugs that reduce the portal pressure. If you want to know the interventional procedure that reduces the portal pressure, of course, the most important is going to be the TIPS. TIPS is a very important interventional procedure that is going to reduce the portal pressure, that too immediately in a short span of time. So what are the indications for TIPS? Because they will ask you about the indications and contraindications in exam. And in fact, the side effects of TIPS is also very important. As far as the indications is concerned, the number 1 indications is refractory varicose bleed. Refractory or recurrent varicose bleed, that's the number 1 indication and the most common indication for TIPS. And second one is refractory ascites, number 2, as I told you. And third is refractory hepatorenal syndrome. So especially patients who are having hepatorenal syndrome, but awaiting for liver transplantation. So it acts as a bridge to liver transplantation. And number 4, patients who are having hepatic hydrothorax. As I told you, hepatic hydrothorax is also due to ascites only, because ascites is the one that enters the pleural space causing this hepatic hydrothorax. And sometimes it can be used in patients with SOS, that is sinusoidal obstruction syndrome, which happens in post-hematopoietic stem cell transplant scenario, where again, because it's post-sinusoidal, but not in the hepatic vein. So the hepatic vein is okay here. So if you see, even in SOS, it's a post-sinusoidal problem where the free hepatic venous pressure is actually normal. Only the wedge hepatic venous pressure is raised. So which means here also, if you shunt, it will be much beneficial. So it will be beneficial there. So always you have to shunt the blood from a region of higher pressure to the region of lower pressure, then only the shunt will be effective. If you have 2 areas of high pressure, the shunt is very unlikely to be effective. Number 6, last but not the least, Budd-Chiari syndrome, where it will not be that effective, as I told you, because you are shunting from a region of 2 high pressure areas. So it's unlikely to be that effective, but still you can try in Budd-Chiari syndrome. as a part of failure of conventional treatment. So once the conventional treatment like anticoagulation and all this stuff fails, then you can probably think about doing a TIPS in this kind of scenario. So these are the 6 usual indications for doing a TIPS, but very common indication is the refractory variceal bleed. And what are the areas where TIPS will not be effective? Can you tell what are the areas where TIPS will not be effective? Anyone? I mean, this you must be able to tell easily. So this question is for the audience, by the way. So what are the areas where TIPS is unlikely to be effective? Of course, yes, encephalopathy. Okay, correct. So TIPS is not beneficial in encephalopathy. What else? Yes, TIPS is not effective in pre-hepatic portal hypertension. Any pre-hepatic cause, pre-hepatic, pre-sinusoidal cause, TIPS will not be effective. Then what else? Any pre-hepatic, for example, in extrahepatic portal vein obstruction or portal vein thrombosis, splenic vein thrombosis, TIPS is not going to be effective. Schistosomiasis, TIPS is not going to be effective unless and until there is a sinusoidal component involved. TIPS will not be effective. Then, if you want to correct coagulopathy, TIPS will not be effective. As I told you, coagulopathy is another sign of a liver cell failure, and it is not a problem due to high portal pressure. So in coagulopathy, TIPS will not be effective. And other technical issues are there. For example, for primary prophylaxis of variceal bleed, so TIPS will not be effective. And there's been multiple trials which have shown that preemptive TIPS is not that effective unless until you have certain indications for that. So primary prophylaxis of variceal hemorrhage or TIPS to prevent variceal hemorrhage will not be effective. Once the variceal hemorrhage happens, then you can do TIPS. But before getting incidence of variceal hemorrhage, doing a TIPS is not beneficial and it's been proven. And the other pulmonary complications of TIPS, other pulmonary complications of portal hypertension, TIPS will not be effective. So like portopulmonary hypertension, hepatopulmonary syndrome, TIPS is not shown to be effective. Even though there are controversial trials telling that TIPS can be useful in certain patients with hepatopulmonary syndrome, but nevertheless, there are multiple different trials that proved subsequently that TIPS is not effective in other pulmonary complications of portal hypertension like portopulmonary hypertension and hepatopulmonary syndrome. It's not effective. Apart from that, to correct hypersplenism, if your main thing is to correct hypersplenism, TIPS is not effective in this situation as well. So for example, hypersplenism usually results in severe anemia sometimes and thrombocytopenia and leukopenia. All these things may be there because of high portal pressure that is sequestering the blood cells within the spleen. So that will result in cytopenias like anemia, thrombocytopenia, and leukopenia. Very common thing that we encounter is thrombocytopenia, one of the first things to happen. And after that, you will get anemia, and slowly you can get leukopenia in these patients also because of sequestration of the blood cells within the spleen. That's what we call as hypersplenism. And more the blood cells sequestered within the spleen will enlarge and the macrophages will proliferate, and more macrophages means more blood cells will be destroyed. So that can also predispose to the development of more jaundice. But nevertheless, so that is different. So this is what we call as hypersplenism. To correct hypersplenism alone, TIPS is not beneficial. So then we are going to the contraindications of TIPS. What are the contraindications? Number one, hepatic encephalopathy. Any pre-existing hepatic encephalopathy, especially if it is moderate to severe, you cannot use TIPS because TIPS itself is associated with more portosystemic shunting, so you cannot use. And in patients who are having severe heart failure or tricuspid regurgitation, especially severe tricuspid regurgitation, you cannot use TIPS because TIPS will increase the blood flow into the systemic circulation and more blood is actually entering into the right heart. So in patients who are already having heart failure and TR, TIPS is not going to be beneficial and it's going to cause more harm. So it's contraindicated there. And if the pulmonary pressure, the mean pulmonary artery pressure, if it is more than 45 millimeters of mercury, it's a contraindication. So already TIPS is not beneficial in pulmonary complications of cirrhosis like hepatopulmonary syndrome and portopulmonary hypertension. Coupled with that, especially if the pulmonary hypertension is very severe, that if the pulmonary pressure is more than, we're talking about the MPAP, mean pulmonary artery pressure, if it is more than 45 millimeters of mercury, that is a contraindication for doing a TIPS. And at the same time, if the patient is having uncontrolled infection or sepsis, this is a general contraindication. If the patient is having unrelieved biliary obstruction, like a CBD calculus or something, these are only for theory. If the patient is having hepatocellular cancer, you cannot do a TIPS. In hepatocellular cancer, you have to do something else, which we'll be discussing later on if there is time. And if the patient is having hepatic cysts, TIPS is contraindicated. So these are the usual contraindications for TIPS, which you need to know for exams. So most important contraindication is the first one that is very commonly asked in exam is hepatic encephalopathy is basically a contraindication for TIPS. And what are the complications of TIPS? What are the complications? There are multiple complications of TIPS. Like for example, you can get cardiac arrhythmias, especially AF, suppose because of the high volume that is entering the right heart and the left heart after TIPS. And sometimes you can cause capsular punctures. So if you do capsular traversal, capsular puncture, because of that, sometimes you might get hemoperitoneum, but capsular rupture is not a, like very significant complication, because even though capsular rupture happens in almost 1/3 of the patients, almost 33% of the patients will experience capsular rupture, but association with significant hemoperitoneum is basically rare. And you can develop bleeding. So bleeding is common, but very commonly, like you can get from the main portal vein. So that's the reason why when you are using that communication between one of the hepatic veins and into the portal vein, don't use the main portal vein. Always they'll be using the one of the branches of the portal vein. That's why if you see the diagram here also, I'd have mentioned in one of the branches of the portal vein. So the branches of the portal vein only you are going to use. So if you use the main portal vein as a conduit, there is a high risk of developing bleeding in that situation. And you can get that thrombosis of the graft. So the PTFE is what you're going to use. But if you use PTFE, it's very rare to get thrombosis. But in general, you can get thrombosis of the grafts, which is also one of the combinations. The current PTFE grafts, it's very rare to get a thrombosis. And most important is the portosystemic encephalopathy. So that is called post-TIPS encephalopathy. That is called PSE, portosystemic encephalopathy. So it is the most important of all the complications, and it's one of the early complications that can happen after TIPS. So portosystemic encephalopathy can be early as well as late. Most of the portosystemic encephalopathies will be there within 2 to 3 weeks after stent placement. So this is a usual common location. Mostly will be evident within 2 to 3 weeks after the stent placement. And usually precipitating factors will be the same as that of other precipitating factors for other hepatic encephalopathy, which we'll be discussing in some time. And if they ask you the most common complication after TIPS placement, once again, the examiner is expecting a portosystemic encephalopathy. Remember, whenever they ask you most common complication of TIPS, usually answer will be capsule rupture only, capsule traversal only, but it's not significant complication. But if the examiner has not given capsule traversal, and if they have given most common complication, usually it will be a portosystemic encephalopathy, or post-TIPS encephalopathy is quite common. And if they ask you the refractory, they will ask you refractory treatment is by standard hepatic encephalopathy management only, which we'll be discussing after some time. So we have a lot of things to discuss. So after some time, we'll be discussing the standard treatment of hepatic encephalopathy will apply here also. But if it's refractory, as I told you, only one option is there, that is orthotropic liver transplantation. Transplant is the main thing. But there is always a bridging procedure. Transplant is not that easy to do. Suppose if it's a refractory thing, so you can actually cause a iatrogenic stent occlusion. This will be serving as a bridging procedure till you take the patient for transplant. So that is called iatrogenic stent occlusion. Usually we embolize the stent. So which means the shunt is the one that is causing the encephalopathy. So prevent the shunt and prevent the movement of ammonia into the systemic circulation. So, I mean, you have created a shunt. Now you occlude the stent, like by causing embolization. So this is a bridging procedure to prevent to treat the refractory encephalopathy till you take the patient for a hepatic transplantation, orthotropic liver transplantation. So remember, in exam, if you don't have the option of capsule traversal, the most common complication is always post shunt encephalopathy or post-TIPS encephalopathy is going to be the most common complication. But if you have capsule traversal, then you can go further. But I feel it's only theoretical because usually that will not cause any much serious impact. And the incidence of hemoperitoneum due to capsule traversal is extremely small. And hemoperitoneum is very, very rare. So you don't really get that. So usually the most significant post-TIPS complication will be the post-TIPS encephalopathy only, or post-shunt encephalopathy or portosystemic encephalopathy. That is what you're going to get, called as PSC. And apart from that, TIPS related problems are there, which can result in hemolytic anemia, where because of the movement of the blood against this stent, like that can shearing of the RBCs will happen. Because of that, you can get a microangiopathic hemolytic anemia. And you can get hyperbilirubinemia again because of the hemolysis that you get because of the microangiopathic hemolytic anemia. Stent infection can happen, which is a very late complication, and stent stenosis can happen, which is also very late complication. All these things is very, very infrequent nowadays. The most significant thing, once again, I'm telling, is the portosystemic encephalopathy or post-shunt encephalopathy, or otherwise referred to as post-TIPS encephalopathy. That's going to be the most significant of all. And we have some surgical shunts also. Interventional, we have told about the TIPS, but surgical shunts are also there, which are infrequently used. We have different types of surgical shunts. One is non-selective surgical shunts, and we have selective surgical shunts. There are 3 non-selective surgical shunts. In that itself, if you want to differentiate, I can tell it is total surgical shunts, total non-selective shunts, and probably we have something called partial shunts also. What are total shunts? Total shunts are portocaval, where directly you anastomose the portal vein with the IVC. Then we have the mesocaval, so where you anastomose the superior mesenteric vein with the IVC. And next we have something called as a splenorenal shunt. Splenorenal shunt, especially the proximal splenorenal shunt, will be a non-selective shunt only. Why I'm telling this? Because here you will do splenectomy. That is very, very important. So in a proximal splenorenal shunt, otherwise referred to as a Linton shunt, you are going to make an artificial connection from the splenic vein into the IVC. At the same time, you remove the spleen also. Spleen is removed in a proximal splenorenal shunt. So splenic vein to IVC plus spleen is removed. In a partial shunt, only one is there. That is called Sarfe shunt. Sarfe shunt, which is a quite complicated procedure. That's the name is very important. It's a small diameter portocaval shunt. It is like portocaval shunt only, but only a side-to-side anastomosis will be done, not rather than doing an end-to-end anastomosis. Very, very small shunt. So that's a partial shunt. That's called a Sarfe shunt. As far as selective shunt is concerned, you have a distal splenorenal shunt. Distal splenorenal shunt, which is also referred to as something called as a Warren shunt. You would have studied in surgery. The most important difference between a proximal splenorenal shunt and a distal splenorenal shunt is the fact that the spleen is not removed here. So that is the most important difference between a proximal splenorenal shunt versus a distal splenorenal shunt. And second, we have left gastric vein to the vena cava. So this is called a left gastric vena caval shunt. That's called Inoguchi shunt. Inoguchi shunt. So mesocaval shunt also has a special name for that. That is called as Drapana shunt. So, I mean, don't get boggled by the names. So the currently preferred shunt, if at all you want to prefer a surgical shunt, it's always the Warren shunt. That is what is preferred. So that's the only thing that you need to know. If at all you want to know something for exam, the distal splenorenal Warren shunt, where the spleen is not removed and only the splenic vein and the renal veins are anastomosed here. So this is what we called as a distal splenorenal shunt. So in the conventional splenorenal shunt, that is proximal, the spleen is removed. That's called a Linton shunt. So that is different. So these are the surgical shunts, but remember, surgical shunts usually will not be a question exam. So if at all you don't have time, you can exclude this. And the most important is always going to be the TIPS, which is a interventional procedure, which plays a very important role in the management of portal hypertension patients, especially those who are having sinusoidal hypertension like cirrhosis. Remember, the most common cause of portal hypertension is cirrhosis only. That is sinusoidal hypertension. So if you understand portal hypertension, then we can move on to next complication. Do you understand this? We can move on to the next complication. That is ascites. Yes, okay. So what all we have discussed till now? So let us recap from the beginning. So you have discussed the types of portal hypertension. Then we have moved on to the pathophysiology of portal hypertension. Then we saw what are the main problems due to portal hypertension. Then we saw how to diagnose portal hypertension, in that how to diagnose using HVPG and how HVPG correlates with different complications at different stages, and what are the drugs to reduce portal pressure, and what are the interventional modalities to reduce portal pressure, and what are the surgical modalities to reduce portal pressure. And the most important interventional modality that we use is TIPS, and what are the indications for TIPS, and what are the contraindications for TIPS, and what is the most important complication of TIPS, that is post TIPS encephalopathy, that is portosystemic encephalopathy, which is the most common complication, and how to manage with that. So this is what we have discussed till now, which all of which are very, very important. And many of the times, I don't know whether they will be asked in NEET or not. They might give some clinical scenario, but the most important thing here is to note that this will be very common in the institute setup. Maybe in the next INA CET, they might ask, and whether INA CET will be there next time or not, we don't know. But because of the number of changes that are happening in our current scenario, but if at all the INA CET happens again, so you might get these kind of questions, which are very common there. And next complication we are going to manage is ascites. Ascites is a very important complication. As far as ascites is concerned, so first we need to find out the etiology of ascites, which is really, really important. So the most important here is the SAG ratio. The SAG is what we are going to use as a very important entity to classify the ascites in the first place. First of all, what is SAG? So how will you, this called a serum albumin and ascites gradient. So you take serum albumin and you subtract with ascitic fluid albumin. So this is what we refer to as something called as SAG. So that is called a serum albumin ascites gradient. So based on SAG and the total protein, we can classify ascites into a low SAG, low protein, high SAG, high protein, low SAG, low protein, and high SAG, low protein. So we can classify into different varieties. So first, let us write SAG on one side, that is serum albumin ascites gradient, that is either more than or equal to 1.1 or less than 1.1. So this is what we refer to as a high SAG, and this is what we refer to as a low SAG. And you can also write the protein content in the ascitic fluid on one side. So whether it is less than 2.5 grams per deciliter, or if it is more than 2.5 grams per deciliter. So this is the ascitic fluid protein that we are talking about. So remember, whenever you have a high SAG, I've told you multiple times in the past, that is equal to portal hypertension. That's all. So that is equal to portal hypertension of some cause. That's all. That's the only cause. Nothing else. You cannot think about anything else apart from portal hypertension in this particular scenario. So that's what the pathophysiology is. And when you have a high SAG and a low protein, typically you think about a sinusoidal cause. Sinusoidal cause. So sinusoidal cause in the sense you typically think about a cirrhosis, number one. Sometimes it can happen in a few other pre-sinusoidal causes, but the usual important thing here is the sinusoidal cause, because only in sinusoidal causes like cirrhosis you will have a liver failure, and because of that you will be having a low protein in this scenario. Clear? Because this is problem of synthetic function in the liver, so you'll have a low protein, means definitely you're dealing with a sinusoidal problem like cirrhosis, which causes low synthesis of proteins in the body. And if you have a high SAG and high protein, it must be portal hypertension only. But high protein means it's not cirrhosis. So you can think about other types of portal hypertension like pre-sinusoidal, pre-hepatic, or you can even think about a post-sinusoidal and post-hepatic. You know what are the examples of pre-sinusoidal? Pre-sinusoidal example is schistosomiasis and NCPF, and pre-hepatic pre-hepatic is NCP, EHPO, pre-sinusoidal is schistosomiasis, and post-sinusoidal is veno-occlusive disease or SOS, that is sinusoidal obstruction syndrome, and post-hepatic characteristic example is Budd-Chiari syndrome and cardiac problem. So cardiac problem, Budd-Chiari syndrome, all these things will result in development of this kind of high SAG and high protein ascites only, very characteristic. And whenever you have a low protein, low SAG, it is definitely not portal hypertension. That's how I used to remember, and this is how I want you to remember as well. So whenever you have a low SAG, it's very clear that you are not dealing with the case of portal hypertension in the first place. When you have a low SOG and a low protein, this is a very rare combination. So you get a low SOG and low protein. Whenever you get this combination, you have to reassess the patient because it's very, very rare. So why you get a low SOG? Because it's not portal hypertension. But why you get a low protein? Because the protein is leaking somewhere. Some other cause of hypoalbuminemia can be there. Like for example, it could be nephrotic syndrome, or it could be a protein losing enteropathy. So some other cause of hypoalbuminemia is causing the ascites. Or very rarely it could be due to mixed edema. But these are very, very rare conditions. Usually you don't encounter. And when you have a low SOG and a high protein, is the typical exudative ascites. So where you get in tuberculosis, where you get in pancreatic ascites, called as pancreatic ascites, because of pancreatitis you get ascites, or it could be due to chylous ascites, typically exudate. And if you get in a malignancy, peritoneal carcinomatosis, where there will be some cancer that is causing seeding of the cancer in the peritoneum. So these are the usual causes of low protein and low SOG and high protein ascites. So typical exudate. So these are your classify ascites. In that, whenever you have high SOG, it is portal hypertension. Whenever it's low SOG, it is not portal hypertension. High SOG, low protein, think about cirrhosis. High SOG, high protein, think about other cause of portal hypertension apart from cirrhosis. When you have a low SOG, low protein, think about hypoalbuminemia. Whenever you have a low SOG, high protein, think about characteristic exudative ascites like TB, malignancy, chylous ascites, or probably even pancreatic ascites. This is how you are going to classify ascites in the first place. Clear? To diagnose ascites is quite simple. You want me to write or not, I don't know, but the most sensitive investigation to diagnose ascites is going to be the ultrasound. Ultrasound can detect as little as 30 ml of ascites. So even though it cannot be tapped using ultrasound if there is only 20-30 ml, but still ultrasound can detect as little as 30 ml of fluid in the peritoneal space. So ultrasound is going to be the best initial test, and it's going to be the best screening test or most sensitive test. Everything answer will be ultrasound only. And as far as treatment is concerned, of course, number one, you are going to treat the underlying disease. Treatment of underlying disease, if possible, most of the times it may not be possible, but it's better to treat the underlying disease, number one. And the patient should go for complete alcohol abstinence if the patient is taking alcohol. So you have to treat the underlying disease. And next is sodium restriction. Sodium restriction is a very, very important strategy because sodium overload will happen only if the patient is taking sodium restriction, sodium containing diet. And once you restrict sodium, there will be no sodium to absorb in the first place. So sodium restriction is very, very important. Typical amount that is advised to patients is less than 2 grams per day, which roughly equates to less than 88 milliequivalents per day. 88 milliequivalents of sodium per day. So either less than 2 grams per day, which roughly equates to less than 88 milliequivalents per day. And plus or minus fluid restriction is quite controversial. Generally, fluid restriction is recommended only if the patient is having associated hyponatremia. So otherwise, fluid restriction is generally not recommended. So if the patient is having hyponatremia, then fluid restriction can be recommended. Especially if the sodium is very low, then you can recommend fluid restriction. So number 3. Diuretics, which is what we are talking about. Diuretics. The 2 diuretics that we typically use is, one is furosemide Lasix, very commonly used drug. Along with that, we are going to use a spironolactone. So they will definitely ask you in what ratio you should add. You should add in the ratio of 1:2.5. So 1:2.5 is the ratio that we add these drugs. And you always add in a combination. You never add one drug alone. So that's the usual norm in cirrhosis. So for example, you generally start with probably maybe 10 milligram of furosemide. Then you can give 25 milligram of spironolactone. Then you give 40 milligram of furosemide. Then you're going to give 100 milligram of spironolactone. So typically you can go to the maximum dose of approximately 160 milligram of furosemide, and you can go up to 400 milligram of spironolactone. So this is the maximum. So maximum dose of diuretics, if they ask you, 160 milligram of furosemide with 400 milligram of spironolactone. Clear? And usually when you give diuretics, usually the weight of the patient is the one that comes down first. So usually we assess the response to diuretics by seeing the weight of the patient. The recommended weight reduction in a patient who is very edematous is 1 kilogram per day. If the patient is having significant peripheral edema, then the amount of weight reduction that is recommended per day is approximately 1 kilogram per day, which means to increase the dose of these diuretics, you need a target. So what is the target? Target is basically the weight of the patient. Suppose the patient is having significant peripheral edema, hands, legs are all swollen, then the target will be 1 kilogram per day to come to achieving the dry weight. Or if the patient is having no peripheral edema, only ascites, then in these individuals you can give approximately half kilogram per day. So depending on whether the patient is having peripheral edema or not, your targets will vary. Having peripheral edema means 1 kilogram per day. Not having peripheral edema means half kilogram per day, or maybe 300 to 500 grams per day. So that will be the ideal weight loss. And depending on that only, you are going to titrate the diuretics in the first place. Clear? So then number 4 is something called as therapeutic paracentesis. So you have therapeutic paracentesis. So to achieve rapid reduction of ascites, you can go for this therapeutic paracentesis. If you want to remove the ascites urgently, because in some patients the ascites may cause significant problems with regards to quality of life of the patient, because the abdomen may be very tense and causing a lot of issues to the patient. In that situation, it's advocated. So there is something called large volume paracentesis. Any amount of fluid can be removed. Suppose if you remove more than 5 liters in a single sitting, so this is what we refer to as something called as a LVP, or otherwise referred to as large volume paracentesis, or otherwise referred to as LVP. So whenever you do a large volume paracentesis, you always have to add albumin replacement. So you should not do large volume paracentesis alone. Always try to do albumin replacement as well. So suppose if you are removing less than 5 liters, generally there is no need of adding albumin in the first place. Suppose if you are doing large volume paracentesis, that is the time you will be needing albumin replacement. That is also a very important thing to know. So how much albumin you need to add is a question. So for every 1 liter you remove beyond 5 liters, so you have to add 6 to 8 gram of albumin. So the amount of albumin that has to be replaced is approximately 6 to 8 gram for every liter. For every liter of acidic fluid that is removed, 6 to 8 gram of albumin per every liter of acidic fluid that is removed, you have to add. For example, if you are removing maybe 4 liters, if they ask you an exam, you don't need any albumin at all. Suppose if you are removing 6 liters, then probably I can take 6 to 8 as an average, means I think you'll be needing 36 to probably 48 gram of albumin is what is added. Suppose if I'm removing 10 liters of acidic fluid, then I need to definitely add 60 to 80 gram of albumin is recommended. So if you remove less than 5 liters, no need of albumin. Anything more than 5 liters, for every liter you remove, you have to add 6 to 8 gram of albumin to the patient. So which is very, very important. So this is large volume paracentesis. And what kind of albumin you have to add? As I already told you. So remember, you always add 20% albumin. You never give 5% albumin, because 5% albumin contains less albumin and more of sodium, that is used in patients who are having hypovolemia and dehydration. For resuscitation purpose, you use 5% albumin. But for liver related purposes, you're always going to use only 20% albumin, which contains more albumin and less salt. So suppose if a patient is hypervolemic, like those in cirrhosis, and you want to give volume replacement, always prefer a 20% albumin. So that's also referred to as vaguely by some gastroenterologists as salt-free albumin, but that term should be avoided. It's better to use the term called 20% albumin. So that's what we're going to use. So what are the therapies that we used? You used sodium restriction, which is very important. Fluid restriction only if the patient has hyponatremia, which is an evidence of dilution. So that's why we give fluid restriction. Diuretics and therapeutic paracentesis. These are going to be the most important options. Over a period of time, the patients may exhibit resistance to diuretic. So whenever the patient has diuretic resistance ascites, that is also referred to as something called as a refractory ascites. If serum albumin is low, then how SAG ratio can be high? Confused in SAG table. Where is that SAG table? Where is that? Serum albumin is low. Okay, how? SAG ratio can be high. Okay, you're asking this one. I mean, this is not the serum albumin. I think you are confused again. That's why I clearly wrote it's the protein. Protein doesn't include only the albumin. Protein includes albumin, globulin, all these things. And in in cirrhosis patients, you will have a reversal of AG ratio. Reversal of AG ratio means the more the albumin they reduce, the more the globulin they produce. And there will be reversal of age ratio in patients with cirrhosis, which I think discussed in the previous lecture itself. But nevertheless, the protein is not we are talking about. I mean, the protein is different from the albumin we are talking about. So albumin is different and the protein is different. Both are completely different here. I think you're confusing the albumin and the protein here. I think so. Do you get it now? So what is the difference between protein and the albumin? Do you understand? Yes. So this is not the albumin that we're talking about. It's a protein. Okay, fine. So we are actually talking about a refractory ascites. So what is the meaning of refractory ascites? Whenever the patient is having a diuretic resistant ascites, that's where we typically call it as a refractory ascites. So we don't use the term refractory ascites nowadays, except in the Child-Turcotte book scoring. But nevertheless, it's renamed as something called as a diuretic resistant ascites, where the diuretics are no longer effective in controlling the ascites. So when you call it as a diuretic resistant ascites, whenever the patient is having persistent ascites that is persistent, plus patient is on a sodium restricted diet. So if the patient is not adherent to a sodium restricted diet, that will not be called as a diuretic resistant because the patient is non-compliant there. Plus you're already using maximum diuretic dose. The patient is on a maximum diuretics dose. That is 400 milligram of spironolactone and 160 milligram of furosemide. This is the number one definition. This is the most important definition. Apart from that, second definition is the patient is having a rapid reaccumulation of fluid after therapeutic paracentesis. So you have done a therapeutic paracentesis, and the patient is going for a rapid reaccumulation of fluids. Rapid reaccumulation of fluid again in the peritoneal cavity. So patient, of course, the patient should be on sodium restricted diet. So the patient should be on a sodium restricted diet. So you do a therapeutic paracentesis and the patient is getting a rapid reaccumulation of fluid and the patient is of course on a sodium restricted diet. So this is the second definition of diuretic resistant ascites. So but usual thing that they will be asking in exam is the persistent ascites in a patient who's on a sodium restricted diet and the patient is receiving a maximum diuretic dose. So this is equally important as that of resistant hypertension definition, which we have been discussing for a long. So whenever the patient is having diuretic resistant ascites, what you're going to do in the first place. So first you need to confirm that the patient is having diuretic resistant ascites or not. For that, you need to use 24-hour urinary sodium to see the urine sodium output. Then I need to see the urine sodium potassium ratio. Then I need to see the weight loss that is happening in the patient with diuretics. Then I need to put the interpretation accordingly. Suppose the 24-hour urinary sodium is more than 78 milliequivalents and urine sodium potassium ratio is more than or equal to 1, which clearly tells you that the urine sodium excretion is more. And if the patient is having a good weight loss, this will tell you that the patient is having a good sodium excretion, which means the patient is diuresis sensitive. The patient is diuretic sensitive. But the problem here is the patient's 24-hour urinary sodium is very high, which means the patient is having a low adherence to sodium restricted diet. So the patient is not actually adherent to sodium restricted diet. The patient is taking too much of sodium in the diet. That is why the 24-hour urinary sodium is high and the urine sodium potassium ratio of more than 1 tells you that the patient is diuretic sensitive and the patient is having a good weight loss, means this is not a diuretic resistance. Suppose if the 24-hour urinary sodium is more than 78 milliequivalents and the urine sodium potassium ratio is more than 1, and if the patient is not having weight loss, in the sense like this is the time where the patient is going for one second, hold on.